It's been an extraordinary year for telehealth, as hospitals and health system leaders well know, but what lies ahead in the next 12 months? How has the adoption of virtual healthcare changed and challenged our medical workforce, and how do organizations need to respond? I'm Molly Gamble, Vice President Editorial for Becker's Healthcare, and to learn the answers to these questions and more, I'm delighted to serve as your moderator today for a panel with 4 telehealth leaders from across the U.S. Today, I am joined by Dr. Lisa Finkelstein. She is the Medical Director of Telehealth with St. John's Health in Wyoming. Dr. Siobhan Rary, she is the Director of Telehealth for Cancer Treatment Centers of America. Maya Hightower, she is the Chief Medical Information Officer with the University of Utah. And Rebecca Canino, Administrative Director in the Office of Telemedicine with Johns Hopkins Health System. Panelists, welcome. Thank you so much for being part of this conversation today. I am really looking forward to the ground we're about to cover. Before we do so, I'm going to ask you each to share a bit more about yourselves and your organizations, and then we'll dive right into some of the questions we're setting out to answer. Lisa, let me ask you to begin.
Hi, Molly. Thanks for inviting us to this wonderful panel today. So I'm the medical director of telehealth at St. John's in Jackson Hole, Wyoming. And I'm also a urologist. My passion in telemedicine really started many years ago. I was driving back and forth 150 miles to a clinic and flying 45 minutes to another clinic. And I did that for about 13 years. And I knew there had to be a better way. And that was through telemedicine. So I started thinking about it back in about 2009.
Pioneer. Thank you very much, Lisa, for being here. Rebecca, can I turn to you next?
Absolutely. Thank you. My name is Rebecca Canino. I'm the Administrative Director for Telemedicine for Johns Hopkins Health System. And telemedicine is so vital to us, spanning the inpatient and ambulatory space from primary care to subspecialty, and bringing along research and helping that move forward.
Thanks for joining us, Rebecca. And Siobhan?
Hello, good afternoon. Thank you for having us. So I am Siobhan Rary. I'm an endocrinologist by training, and I'm board certified both in internal medicine and endocrine. I am the National Program Director of Telehealth at CTCA and the Medical Director of Endocrinology. I've been in this space for over 10 years. I, at this current state, deploy a systems level thinking approach to build, strengthen, and execute our telehealth clinical strategies and services. And CTCA is a national oncology health system network of about 5 geographically diverse hospital systems, 10 outpatient clinics. We have a single EHR in 3 different time zones. So all of that played into a role in scaling our program, and I'm happy to share that experience with you all today. Thanks.
Thank you, Siobhan. And finally, Maya.
Hello, Molly. Maya Hightower, I'm the Chief Medical Information Officer, as well as Senior Director for Health Equity, Diversity, and Inclusion here at the University of Utah Health. I'm a practicing internist, and I continue to serve really all parts of the Tripart mission. I'm here at the University of Utah Health. We're the only academic medical center in the Intermountain West. So not only do we service primary, tertiary, quaternary care for the state of Utah, but the entire Intermountain West. We provide care not only to our urban center, but definitely have a great commitment to our rural population that spans across a huge section of the United States. So thank you. Happy to be here.
Likewise. Thank you, Maya. So let's start the conversation by a little bit of a look back in the rearview mirror of what gains were made with telehealth in the past year. More gains were definitely made in the past year than the past decade, but I'm curious to hear in your words what that looked like for your organizations. Lisa, can I ask you to kick us off on this thought?
Sure. I think that telemedicine biggest gain for us was really keeping patients and providers safe at home with the pandemic. And like you said, the pandemic really accelerated the whole process of access for patients to specialists. And it was very interesting for me because back in 2019, I began putting a team together for telemedicine, again, recognizing the gains that telemedicine could provide, which is bringing better access to care for our patients. So we were very lucky because I had to lead by example and started practicing teleurology back in 2019 to my patients in Pinedale, Wyoming and Rock Springs, Wyoming. Also initiated with U of U, with our tele programs that we had already in place. And so the gains that we made were having the structure already in place, and then getting providers to change their old habits of being able to pivot to seeing patients virtually. And that is a huge win for everybody. It was difficult to get providers to buy in, but that's been a big gain and due to the pandemic that everybody had to really do that on a dime. The other gain was being able to rearrange our days and make things more efficient, and recognizing how much time was wasted in bringing a patient into the clinic to get care, and then have to drive to a pharmacy and take off work and drive and fly and all of that stuff. So that was a very large gain, and to recognize how telemedicine can make care much more efficient.
Thank you, Lisa. So some really big gains you mentioned here: keeping patients and providers safe, getting providers, inviting them to change their habits, and then these efficiencies and these newfound appreciation for patient time, and kind of a look back at how much time in the past had been wasted we could otherwise use more efficiently. Anything else, panelists, that you would add to this running tally that Lisa put forth of the gains you've seen?
Yeah, I would add that in a time of isolation, it provided connectivity, right? So for family to be with their loved ones in the hospital, I think was huge as we went into lockdown, and just talking to each other via telemedicine was so important. And also access to behavioral health for both providers and patients through this time has been, we can't even quantify what that has saved us and allowed us to continue through this time. I think another thing on the academic side is that it's allowed us to keep teaching, which has been a huge part of our mission, and it's allowed us to give our learners immediate feedback that wasn't available before, right? You can actually be texting your fellow while they're providing care, right? And giving that immediate feedback during and after.
I think those are great points. I would like to add that for us, it was certainly in the peak of the pandemic, we were utilizing telehealth to stay connected to our patients, is what we've expressed here. Clinical trials, we were able to maintain patients on clinical trials as needed. And as the pandemic moved and continued, we were able to pivot to a hybrid model, so a bridge to on-site care or augment of the in-person care. So making sure that we stayed connected with patients and managing their symptoms was important. And then we shifted to a partnership-driven approach where we're utilizing telehealth to bridge those gaps, to provide access to care in rural health, and looking at innovative care delivery models, such as chemotherapy in the home with telehealth oversight. So in the cancer space, we found a number of benefits that we continue to use.
Wonderful. Maya, are you about to say something?
Oh, sure. Absolutely. I mean, without a doubt, scale, of course, scale to our patients. And so that has been an incredible gain. Scale for our providers. We went from 2% of our providers doing virtual care or telemedicine to 91% of our providers doing virtual care or telemedicine. But also just maturation of our program. So now we have very clear expectations when it comes to patient experience in the virtual environment. quality and how we measure quality, the drive to innovate, but also being financially sustainable. I think prior to COVID, we didn't have as much, I mean, it was really more as a skunk works, as a pilot, more as an innovation side. But as it became a core part of our care delivery model, it's the expectations when it comes to meeting these types of metrics and aligning with the overarching healthcare delivery strategy really has matured.
So great, you set the stage wonderfully here for the gains and the benefits and how telehealth helps your teams and help patients and providers. Now let's roll up our sleeves and talk about the challenges, because I know there must be some, and I'm excited to hear your thoughts on this point. Maya, I'm going to stay with you to get us started.
Sure, exactly. So challenges. So, as we pivot to the new normal, we've amassed this huge amount of data around, like I said, those sort of four main areas: the experience, the quality, financial model. And now we need to shift to a new normal expectation, which is very different than during the pandemic. And so how do we take those lessons learned, even from the technical infrastructure, to create an exceptional experience where we're winning not based on access, but we're winning really because we're creating exceptional experiences, these sticky experiences for our patients. But also the health system as a whole is able to be successful because we've identified opportunity for the right patient, the right visit type, in order to create growth opportunity with increased capacity in the in-person space. And so I think now the real challenge is taking virtual and telehealth into context of the greater healthcare delivery system and how we are able to reposition ourselves moving forward into the future, into this new normal where we've all had this experience, but now we need to solidify those inroads in a sustainable way.
Maya, I so agree. And I think it's so interesting as we move forward into that new normal, not to take things with us, our preconceived ideas like the waiting room. We don't have to have waiting rooms, right? Like, let's just eliminate those things instead of trying to recreate them. And I think when we're recreating, I think our old roles and responsibilities have to come under review and really looking at that value add, like Lisa said, like, let's get rid of those things that don't add value in the roles as well. And so your CMAs aren't going to be doing the same things as they did before, right? There's now an IT component. So do you retrain? Do you create new roles? How do you look at things through the lens of getting the best out of virtual and the best out of in-person and creating this hybrid model? The other really important challenge that we have as we move forward and build these systems and refine them is keeping equity in mind and making sure that we're not building systems that leave people behind, and making sure that we are creating systems that limit that disparity, that increase access, and just keeping those vulnerable populations at the forefront as we build these systems.
Agreed, and I'd just like to highlight that, at its best, telehealth offers valuable services to the underserved, to isolated populations like we have all expressed on the call here. Those populations that have limited or no access to medical care. And it's imperative that as we move into a post-pandemic state, we ensure that that patient access to technology, to broadband and digital literacy is at the forefront in order to, propagate exactly as Rebecca mentioned, making sure that healthcare and telehealth in particular remains equitable throughout. I think the other challenge that we face is, with CMS, there were more than 100 plus waivers that were put in place in order to ensure telehealth could be utilized to its fullest, whether that includes state or more federal regulatory policies. I think all of that needs to be taken into consideration as we're looking at sustained models, sustained financial models aligned with the healthcare organization, as Maya had mentioned, and then looking at state regulatory models for telehealth moving forward.
I'm just going to add on to what Siobhan just said. Prior to the pandemic, a couple of years prior, I had presented to our legislature and the governor about telemedicine. And, let's get to the point in the sense that if we're not going to get paid, if physicians aren't going to get paid, then they're not going to want to use telemedicine. Same with hospital systems. I think, and I've always been a proponent to say to patients that you need to speak up. If you feel that telemedicine is valuable to you, to be able to be safe at home or to not have to get in your car and drive to a clinic, whether it's in Baltimore or, in Wyoming, then it's important that you speak up to the payers, that you speak up to your legislators and be the champion along with us to say, we need to keep these changes permanent, so that the systems and the physicians can get reimbursed for these services in an equitable way.
So just a real medley here of different challenges you're all seeing. And I want to now learn a bit more about how your organizations or how you see other organizations responding to some of these challenges. So you mentioned, Maya, the amassed data that has been accumulated from telehealth. How will that be used to inform experiences? And then how do you find a way where telehealth really, really fits into the health system and brings value? Also, let's see, Rebecca, you mentioned defending telehealth from the status quo. It does not need a waiting room. How do we really get relentlessly defensive about protecting it from some of these other inefficiencies and ways of thinking that could creep in that have been with us with legacy health systems for a long time? Equitable telehealth. Also, the government and payers' involvement and their role in supporting this and making sure that reimbursement and it's funded appropriately. Some of these things are within your health system's realm of control, others not so much. But do you have any thoughts of those I just shared about how health systems should respond or are responding?
Well, I could start with the data challenges because that is something that is somewhat in our control. But at the same time that data challenges, we've been using some of our traditional ways of managing data, definitely when it comes to patient experience and quality, leveraging our partners such as our patient experience partners like Preskini and Vizient for our quality metrics to ensure that we have almost parity between the way that we measure the in-person experience with the virtual experience, whether it's patient experience or quality, but also internally leveraging our analytics teams to be able to have further insight, especially around the financial models. But that does beg the question of how mature our data and analytics infrastructure is and aligns with digital transformation in healthcare in general, because a lot of the tool set is the same. So being able to leverage digital capabilities in order to really take a deeper dive into our own data and start to be able to predict, and not only descriptive analytics, but actually predict what type of patients would be best suited for, say, a virtual versus an in-person visit. How do we optimize all of the different drivers into an optimization algorithm where we're able to intelligently address the various drivers, whether it's scenario planning all the way to really being able to drill down into the orchestration of the video visit in and of itself. So the maturation of video is only a small component of maturation of digital health transformation in and of itself. It's a use case, but definitely not an ends to itself. So lots of great ideas, and that's where I think virtual is going in general as part of this greater digital transformation within healthcare.
Yeah, and we see so many overlaps with apps that people have on their phone, right? And different health kits from different platforms passively feeding us data, patients manually feeding us data. How do we handle that data? How do we make it simple for the providers to see at a glance and have it really in a timely way affect the treatment plan, right? And make it better for that patient. And so there's so many exciting overlaps when you look at data. One thing that we're really interested in is being able to get that data in, keeping it simple, and then not eliminating all the tools we had before. The phone, amazing, simple. Folks who don't have broadband have a phone, right? And so how can we use audio only? to really serve those patients? And then how can you make your system smart enough, like Maya mentioned, to say this patient video is not going to work, and to alert the provider to pick up the phone and reach out to that patient, and then be able to capture that in the system so that we can look at equity metrics on those dashboards to say, here are our zip codes, here are our vulnerable populations, and what is the best way to reach them? Because we can get that video perfect, right? But if that patient doesn't have access to it, how do we get them care? Partnering with home care, getting people actually into the home for those patients and preventing those readmissions. So there's a lot to consider here.
I think to that point, we're utilizing, additional tools. So telemedicine or audio video, as we have stated earlier, is just one component of an entire transformation and digital care continuum. So how do you utilize remote patient monitoring to stay connected with the patient, to make sure they have access to care where they spend most of their time, which is in the home? How do you couple that with oncology care? And what we're doing at CTCA is doing is moving or extending the care beyond the brick and mortar, beyond the four walls, where there's some patients who may be eligible clinically for chemotherapy in the home. And how do we couple that with telehealth, with remote patient monitoring, to provide that continuity of care and that seamless experience for the patient? Meeting them where they're at. How are we moving care to improve gaps? Where we have a number of rural health partnerships that we've engaged in. So the idea of someone in Watseka, Illinois, with less than 5,000 population, they now have access to world-class oncologists through telemedicine. And how do we make sure that the patients are being seen in conjunction with the rural hospitals and the rural clinics with this oncology specialty. So we take that to heart, and we make sure that we're working with the rural facilities to provide that seamless care and specialty care for the patients.
Yeah, and working with the facilities and intra-facilities is so important, because this could be provider to provider, right, for the benefit of the patient. And so around a lot of those connectivity and those wait times by going direct provider to provider, synchronously or asynchronously. So you must have so much experience with this.
Yeah, absolutely. Our goal is to provide education to the providers, with our rural partnerships and rural communities, but also to be there to support the patients through the treatment. Our patients are fighting for their lives with and without COVID. And we always say cancer doesn't stop for COVID. And, unfortunately that has been the case. With screening significantly down, we certainly expect that, as we're moving in a post-COVID world, we are going to get later stage cancers that we're seeing in our facilities, whether that be in primary care or in specialty care. So we do need to better understand how can we provide the support that's needed, and make sure, that we're following quality metrics and standards of care, and collecting all of that data. Now with the various tools, how are we ensuring that we're collecting the data, being able to have those predictive models? So it's definitely a significant opportunity for us to extend care beyond the face-to-face.
I would just like to add, to the dream of what we're looking at and what we're talking about, is that they say that the bedroom or the hospital room is the new bedroom, or the bedroom is going to be your hospital room. And in order to make that happen, it takes a village. And so you have to have, train the village, have the village. In an area where we have a very small village. So remote patient monitoring is, the next dream that I have, but the reality is that what's the capacity for our providers to engage in this other project? They see Lisa coming towards them and they want to run the other way because they know that I'm going to say, okay, we have this next great thing that we're going to do, and it involves home health and dashboards and nurses and devices. And so these are all great ideas, but it takes a lot for that to happen in academic institutions at Johns Hopkins and at U of U. You know, you have these teams to make this thing happen. It's a lot more difficult in rural Wyoming for that to actually happen. So we still have a ways to go.
I think that's a great overview. And I know in the time we have, you could probably expand quite more, but a bit more, but in the next 12 months of what challenges you're confronting. I have a couple questions just specific to medical workforce in the time we have remaining. And it's just a few minutes here, but you know, my one challenge is that you mentioned how, Lisa, you said that in 1 year, we really nudged providers to change their habits. You had mentioned you went from 2% to 90% of providers using telehealth in your system. Do you foresee a day that will come where a telehealth program, one that is really top of the line and really smart, effective, productive, will that be a draw and a reason for a physician or another clinician to either be drawn to your system, recruited, retained, they don't want to leave because the telehealth program is so strong? Maya, can I get your thoughts on this question?
Sure, absolutely. And that's because we recently did our provider wellness survey, and in the narrative was, I love telehealth. So definitely there were a number of providers that called out not only the benefit of virtual care to their patients, but how it's impacted their lives and the experience of work for some of our clinicians. Now, will it be every clinician? Absolutely not. Just like every clinician isn't a surgeon, right? So there will be those that have had that opportunity to experience virtual care and don't want to go back. And this will be a key driver, an attractor, a differentiator for those health systems that are able to provide that experience, but provide it in a seamless way, similarly to the provider experience in the care delivery model and non-chaotic environment. You know, all the same drivers that we understand about physician burnout, of which the clinical care setting and the efficiency of that setting has so much to do with a seamless experience for the provider. Similarly, in the telehealth space, you know, making sure that that experience for our providers is surrounded by resources and the teams of teams that really make an effective visit occur, and the provider working to the top of their licensure. So I think we have an opportunity to do it even better than say we've evolved the provider experience in our traditional care delivery model, just given all that we've learned about the traditional care delivery model and how that's driven burnout to our providers. So yes and yes.
Thank you, Maya. You know, my other question, and this is just a couple minutes left, but I think you're seeing this come up a lot as companies plan their return to office strategies, and that's what can be lost when people are working separately and remotely. I'm curious if there's any thoughts around what telehealth means for provider collegiality, camaraderie, culture, and if you foresee any need for pivots or changes to be made to telehealth, given any changes you've seen to those important parts of working together. Rebecca, do you have some thoughts there?
Yeah, I really do. We're really intentionally carving out time for silliness or personal time for the team to get to know each other. We're at a point where we're recruiting virtually and people are joining our team virtually. We've never been in the same space together. They've never been to headquarters or been in the office or had a potluck, right? So how do we build that team? And so I think you have to be very, very intentional about this, building a mentorship relationship where you actually never get to go out for coffee, right? So really being aware of the limitations, you know, getting that subtext of emotion, you know, in your text is hard. So making time, making sure there's face-to-face time, making sure you leave time in your team meetings. Just for people to get to know each other and to have those insider jokes. And I think it's super, super important for that efficient team and being able to, in times of urgency, work together that closely.
Absolutely. So the time spent on that silliness, like you said, and building connection is really time well spent, because it can save you from a lot of pain or perhaps misunderstandings and cultural problems down the line. Okay, terrific. Well, you know what, final thought here, I want to check in with Lisa and Siobhan here about, it sounds like a lot has been learned about patient expectations and standards with virtual care as well in this past year. How do you plan to keep those top of mind with your team? We mentioned data and optimization algorithms and so much more, but I think just culturally as leaders, how do you plan on really ensuring that those lessons, 2 to 3 years from now, don't fade away? Lisa, can I turn to you for some thoughts here?
Sure. I'm going to again go to the dream, since I'm a tele-evangelist, is that virtual first is something that I dream of, in the sense that it is the best case scenario will be a hybrid situation, which is where we're at, sort of plateauing right now, where people sort of crave that face-to-face again. But if we really want to do a deeper dive into how we can be efficient, is to look, like Maya was saying, what patients can we see first virtually, and get the most bang for our buck, and also educate patients about the expectations of telemedicine, and to say to them, telemedicine is medicine. And when you're boarding them for a visit, you're saying you need to treat this as like a face-to-face visit, and be prepared, and give them the laundry list of how best to prepare for the visit with your medications, if you can take your vitals. Be transparent with them and say that this is like a face-to-face visit, and it will be billed to your insurance, and you might be responsible for that payment if your insurance doesn't cover it. There's a whole process that needs to go around to set really good expectations of patients. But patients love telemedicine. So it is here to stay, and it's a really exciting time.
I would echo that. I would say, telemedicine in general is a double-edged sword. So while there's significant benefit, the patients get more convenient care, it's fast, they have access to specialty care that they may not have had otherwise. We also need to be very cognizant that we don't deepen the digital divide. And that we need to ensure that the digital divide doesn't exacerbate any longstanding health inequities that we've seen in the healthcare system. And it's really going to be, the onus is on us, the industry, the stakeholders, to make sure that we use telehealth as the great equalizer, and we take into consideration various populations that may need variations in how telehealth is delivered. And then equally, when we're looking at the providers, I think we need to enable healthcare providers to collaborate more remotely on patient treatment. It's a win-win for everybody. It's a win for the providers. It's a win for the patients. They're able to get timely, quality care, and providers are able to share their expertise and make better treatment decisions. So I think we're at an inflection point where we can collaborate with patients and providers to improve healthcare in ways that we may not have had, a decade ago.
I totally agree. I think it's going to be important that we embed telehealth education at every level for all roles on the medical team. Need to be learning about the best way to do a remote clinical exam for their specialty, digital literacy, how to communicate and build relationships. There's just so much to teach that people are making it up as they go along right now, and we need to really give them curriculum, give them best practice, give them some standards, and really assist this next generation of learners. Not only the folks on the front line now, but the next generation, because virtual is the future.
Yeah, I'll just kind of sum it up in that there's been two major cultural shifts during COVID. there's probably been more, but the digital transformation of healthcare acceleration along that pathway. And then the second is really that equity mindset. Disparities have always existed in healthcare, but I feel like more than ever, there is this equity mindset that has culturally shifted. And we need to make sure that we maintain both of these trajectories in order to, as everyone on this panel has emphasized, ensure that we have that we use it as a way to close the equity gap, not widen it further, not only in our digital care delivery model, but our in-person, every way that we deliver care.
Absolutely. Well, Maya, Rebecca, Siobhan, Lisa, this has really just been a terrific conversation. I want to thank each of you for your contributions and sharing your thoughts with us. It sounds like there is quite a bit of work that remains with telehealth adoption, and quite a bit of catch up, like you said, Rebecca, in terms of education and helping our learners. I have great faith that strides will be made under your leadership. So thank you very much for participating in this event and participating in this panel.
Thank you. Thank you for having us.
Thanks,
It's been a
Molly.
pleasure.
Thank you.